Good afternoon, everyone, dear colleagues from all around the world. It's our great pleasure to host you. It is going to be a nice round table tonight. We have a lot of experts here with us. We're going to discuss, we're going to see some preclinical data, we're going to see some clinical data, we're going to discuss about expertise, we're going to discuss about scientific content. So it's going to be a great night for biologics. It's going to be a great night for regeneration. And we're very happy that so many of you are interested in that topic, because this is really something we need as clinicians to speed up wound healing, to increase early vascularization. This is the backbone of any successful bone regeneration or soft tissue regeneration. So the idea behind that round table today is to get all experts in the different fields together and really shed some light on the application of hyaluronic acid, the application of animal matrix derivative, and the application of blood-derived factors on hard and soft tissue regeneration. So it's my great privilege to host some of my colleagues and friends. So please, friends, turn off your cameras. Don't hide behind the curtain. First of all, it's thank you for having Professor Andrea Piloni, who's the chairman of the section of periodontics at the Rome University, which is a great pleasure. True expert in the field of hyaluronic acid, in particular looking into regeneration of dehiscence defect. Andrea, it's great to have you here, and I'm really proud that you share this night with us.
Hi, Stefan. Hello, everyone. Thank you for inviting. Grazie.
The next panelist is Tony Sculian. He's the chairman of periodontics at the University of Bern. Tony, I did so many webinars with you. We really got friends over webinars and also in personal. You are a true legacy in the field of periodontics. I have to say that. Everything we know about animal matrix derivative, we know from you. I don't think there's any presentation where your name is not quoted. So I'm happy to have you to give us a little bit of preclinical background on animal matrix derivative and also the new studies on hyaluronic acid. Thank you for being here, Tony.
So thank you very much. I think I will share my screen.
Tony, let me just introduce Shahram as the third panelist, and then I know you're eager to present, I know, but give me just one more minute to introduce Shahram. Shahram, it's also great to have you here. You're the vice chairman of the University of Frankfurt. You're an oral maxillofacial surgeon, which is always great to have this input here. You definitely have a great expertise in the field of blood-derived products. You have a good view about the market, is what kind of products we have in here. And it's great to have your expertise in that discussion and to have your input into how good are these biologic agents in comparison to the other ones. So thank you, Shahram, for taking part. Okay, with this,
you're welcome. I'm happy to be.
Great. With this, Tony, now it's on you. We wanted to start everything a little bit with preclinical data, because all of us, we're scientists, and it's important not only to say, well, this works on a clinical basis or on clinical feelings, but we also want to know what is the backbone. I mean, are there any studies? Is there any scientific content behind it? And we asked you, who else when not you, to give us some backbone and background in the field of animal matrix derivative. What is the scientific basis we have here for speeding up wound healing, and also giving us some new input on hyaluronic acid, in particular in the field of periodontal regeneration. Just one more thing, if you have questions, please feel free to add these questions in the chat field. We are happy to condense these questions and also to integrate them into the discussion. And with this, Tony, please take over. I'm looking forward to your lecture.
So thank you
Are you still here, Tony?
Yes, I'm here, but I have to. Can you hear me?
Yeah, I can hear you well, but I cannot see your presentation anymore.
I have to do it again. What about now?
Yes, perfect. Go ahead.
Okay, so thank you very much for the introduction, and I'm really very pleased to share this podium with my colleagues, all experts in the field of parental and bone regeneration. And I will not share with you any clinical data, but I will share with you some of the biologic background regarding enamel matrix proteins, but also hyaluronic acid, and also some preclinical studies in animal models. As you all know, enamel matrix proteins, Emdogain, that is the product that we have on the market, is nothing novel, but is still a very interesting product because it has been introduced longer than 25 years in the clinical application. Biologic concept originating from Scandinavia, and in fact, it is considered nowadays as the standard, the gold standard in parental regeneration. So in fact, we are talking about a protein cocktail, you know, a cocktail that is found in the enamel matrix. And we have data from the literature already from the 70s suggesting that these enamel matrix proteins have a role not only on the development of cement, of enamel, but also on the development of root cementum, parental ligament, and alveolar bone. And of course, what we need to understand as a clinician is the fact that the most crucial tissue that we need to regenerate is always the parental ligament and root cementum. And if you are talking about parental regeneration, we do not focus on bone, but we need to focus on root cementum. This is very important. And if you have root cementum and parental ligament, usually the bone will follow. So if you go to the literature, we will find more than 1,000 papers regarding the different biologic effects of Emdogain, but also preclinical evidence and clinical evidence. And to summarize that, what we have, first of all, if you look at the effects on soft tissue cells, namely parental ligament fibroblasts, if enamel matrix proteins interact with parental ligament cells, the parental ligament cells will produce indirectly TGF-beta, IL-6, and PDGF-AB, indicating that they will increase their own production of growth factors. In the same time, enamel matrix proteins have also an effect upon the attachment rate and migration of parental ligament cells onto the root surface. And they also act as a kind of biologic membrane. In other words, they may inhibit or retard epithelial proliferation. And as you all know, we do not want to have epithelial cells in the wound, but we would like to have cells originating from the parental ligament that are triggered to repopulate the area. And of course, we have a certain effect on bone cells, especially in combination with different types of grafting materials, like for example, DFTBA. This is a human bone graft. We call this effect osteopromotive effect, and also a certain effect on soft tissue cells originating from the gingival connective tissue, namely on gingival fibroblasts. And interestingly, we also have some effects on adipocytes. That means that we may have an effect on fat cells and these fat cells may be triggered to differentiate in various directions. Here is one example of one of our studies performed together with Reinhard Gruber, Rick Myron, and Dieter Bossart some years ago. And here we wanted to see whether we may have an effect on fat cells. So what we did is to harvest pre-adipocytes. They are precursors of fat cells. And we may induce adipogenesis by treating these cells with different types of molecules like insulin, dexamethasone, indomethacin, etc. And then, of course, we added endogain in order to see what is going to happen on this pathway. And what we observe is that by adding endogain on these adipocytes, we will block adipogenesis, and that's quite interesting. So we have quite interesting property in these proteins. In other words, if you would add some endogain to your milkshake in the morning, you may lose some weight, and this is very interesting. So if you look at this pathway, we also found out that endogain also blocks the so-called pathway into the formation of adipogenesis, and this interacts via the TGF beta kinase activity. Then, of course, we also wanted to look whether enzymatic proteins have an effect on palatal and gingival fibroblasts. In other words, whether this may be also clinical interesting application. So what we found out that genes are downregulated by endogain in fibroblast and gingival and palatal tissue. And you see the one example of the gene array technology. And in other words, we were able to demonstrate that some genes were upregulated, whereas some other genes were downregulated. But we have a strong effect of endogain on fibroblasts. And this is quite interesting to point out. And you see every single dot is a gene that may be up and down regulated, and then you can evaluate the outcomes with a specific computer system. So what is the conclusion of these experiments is that, in fact, endogain works via TGF-beta R1 kinase, and it has a so-called growth factor-like activity. In other words, if you use endogain, you have a growth factor in your hands. So we wanted to know later on if we may have an effect on intra-bony defects. And here is only one example. We had different types of enyematics formulations: the conventional form, the endogain, or a more liquid format that is called osteogain. And we wanted to see whether we may coat these proteins on collagen sponges. So we did an experimental model in animals. You can see the defects that were created, and then they were plaque infected, and they were did it in different ways. One defect was the control, that was open flap debridement. We also used a carrier, namely kind of collagen sponge soaked in endogain or in osteogain, and then we looked at the healing. So if you have the outcome on this slide, you clearly see in the control proliferation of the epithelium until the most apical part of the defect, and some spontaneous healing. However, the largest part of the defect was filled with soft tissue. If you use endogain coated on a sponge, we have a very nice regeneration apically to the notch, and a very nice peroneal ligament and root cementum. And please observe the newly formed bone, indicating the proof of peroneal regeneration. Now, if we look at Emdogain coated again with a sponge, another biopsy shows you the same histological pattern. And please see very nicely the investing Schrappii fibers in the newly formed cementum. And a novel formulation of enamel-matrix proteins, the so-called osteogain, also led to the same results, clearly indicated by this novel peroneal ligament, cementum, and bone coronally to the notch. And you can clearly see the newly formed structures in the middle part of the screen at a high magnification, or even a higher magnification to the right, indicating the fibers that invest in the newly formed cementum and that connect the root surface to the bone. And if you look to the measurement, you can clearly observe that Emdogain or osteogain that were in fact soaked on this collagen sponge resulted always in a higher amount of new cementum formation, new bone formation compared to the control. And also the tendency that you see is higher than the outcome found with the collagen sponge alone. Then if you look at some other indication, that is the recession, you can see here one study that we published already longer than 20 years ago, together with my very good friend Nikos Donos. So we did an experiment in animals creating recession type defects, and these defects were treated with a coronal advanced flap alone, serving as control, or application of enamel-matrix proteins. So we replaced the flap, and after a period of roughly 5 months, we performed the histologic analysis. And as you can see it on this slide, this is an overview to the left. You can clearly see the apical part of the defect, and coronally to the notch and the area of the notch, we clearly see this dark green line that's in fact newly formed cementum, peroneal ligament, and bone. And you can see the same features at a high magnification, indicating clearly to the right part of the screen peroneal regeneration. And then the next step was to see whether we may use also some collagen matrices as carriers for Emdogain for recession coverage. And this was another study performed with the group of my good friend Yoshinori Shirakata from the Kagoshima University. And here, in fact, we coated collagen matrix with Emdogain, and we replaced the flap coronally. If you look at the outcome obtained with the open flap that was coronally advanced, we have an epithelial proliferation and more limited regeneration of cementum and peroneal ligament, as you can see to the left. If you would use Emdogain, then we have more regeneration of cementum. You see this dark line here on the dentin surface, peroneal ligament and bone. And you can clearly see at a high magnification these structures that have been reformed. If we use the collagen matrix, we had also some regeneration because it acted as a barrier membrane. And the best outcome was obtained with a combination of Emdogain and the collagen matrix, indicating formation of peroneal ligament, cementum, and bone coronally to the notch. And this is another example that clearly depicts the formation of root cementum, peroneal ligament, and bone when we combine EMD and collagen matrix. And then, of course, from a clinician, it is very important to know what can be obtained if we use a connective tissue graft and we coat it with Emdogain, because this is something that we very frequently use in the clinic when we treat recessions. So what we did in another study is, in fact, a very simple experiment. We created recessions, and they were treated either with a coronally advanced flap and connective tissue graft, or coronally advanced flap combined with emdogain and connective tissue graft. And all the defects were created in a standardized model, and they had the same size. Of course, we have left the defect to chronify for a certain period. Then we performed the surgeries, and you can see here enemymatics proteins placed on the root surface. Then the combination of enemymatics proteins and the connective tissue graft, followed by a coronal advancement of the flap. So what you can see here is quite interesting. Clinically, the healing looked very nice, both in the test and the control group. However, when we look here to the right at the first line, this is probing pocket depth, and you compare the outcome after 10 weeks in the emdogain group to that with a control, that means only connective tissue, we have roughly almost 1 millimeter of difference. In other words, the probing depth was deeper in the control compared to the test site. And if you look now at the histometric analysis, what you can observe is that if you place connective tissue alone on the root surface, what you observe is mainly an epithelial proliferation, and the regeneration of cementum and peroneal ligament was confined mainly to the apical part of the defect. However, if we combine emdogain and the connective tissue graft, please have a look at this overview image to the left. We have a higher formation, or a more robust formation of cementum, peroneal ligament, and bone that you can clearly depict to the middle part of the image. Please observe we have here cementum, peroneal ligament, and bone at a higher magnitude in the test and in the control group. And now please have a look at this table, because this is quite interesting and important, especially if you look at two parameters. NC. NC is new cementum. If you combine a connective tissue with emdogain and you look at the other value in the control one, where no emdogain was added, the difference is clinically or histologically and clinically and statistically significant, indicating more formation of cementum in the test compared to the control group. And also, if you look at the length of the epithelium, please observe that when we added emdogain, the length of the epithelium was significantly less in this group compared to the group treated with connective tissue alone. And this fits very well to the clinical measurements. So in fact, what we demonstrated is that it makes sense to add enemymatics proteins onto a debrided root surface, because it may facilitate periodontal wound healing and regeneration. And in fact, we have now this tool in our hands for the clinical use. Also, histologic analysis in human blood biopsies demonstrated formation of peroneal ligament, root cementum, and bone in different types of defects. And this is only one example of a classical publication of our group that is very often cited, published already 22 years ago. And we have now the proof of peroneal regeneration following the use of emdogain. However, some years ago, I also started to be interested in hyaluronic acid. And in fact, hyaluronic acid is nothing new, because you can observe that it was already published in 1934 by Karl Mayer, and it was a substance isolated from the corpus vitreum of the eye. That's why we have the name. And in fact, hyaluronic acid is a large polymeric glucosaminoglycan that accumulates in the extracellular matrix in the wound already at day 3, but we have also a peak after the day 5. And of course, we have smaller or longer chains of this molecule. And of course, I was always very careful about the biology behind the materials. And the first step is always to go to the laboratory and try to find out whether a certain material, a certain molecule might have a biologic effect. So what we did is to look at the biology of two formulations of hyaluronic acid. one cross-linked and one non-cross-linked. And we looked at the proliferation of human parental fibroblasts and human gingival fibroblasts. And you can see that both formulations are more efficient on the proliferation of these cells compared to the control. The control is always this black curve. And if you look now at the migratory abilities of these cells, and these cells were either harvested from parental ligament or from palatal connective tissue graft, you can see here the plates covered with the cells, and the more black dots you can see, the more cells you have on this surface, indicating that the cells like this surface. You can see clearly the difference between the two formulations and the black bar or this plate to the left that is almost empty. And then, of course, we found out that the two formulations trigger expression of prominent indicator of scarlet wound healing that you can see listed on the screen. And they also induce the expression of genes encoding growth factors in primary human parental fibroblasts and human gingival fibroblasts. And then, of course, we wanted to test this concept again in two different types of defects, namely in intra-bony defects and recession type of defects. And again, with our group from Japan, what we did is to create intra-bony defects in animals, and we tried to follow exactly the same experimental design that we did with Emdogain and also the Osteogain some years ago. So we had 4 different groups. One group was treated with open flap debridement, serving as control. The second group received grafting with a collagen sponge, cross-linked collagen sponge. The third group was treated with hyaluronic acid alone, using the product Hyadent, that was the cross-link hyaluronic acid. And the fourth group was the combination of hyaluronic acid and collagen matrix. You can clearly see the clinical image during surgery, and we have the different defects. Clinically, the healing went well in all defects. No complication was visible in any of the defects. And now if we look at the histometric measurements, what you can observe is in the open flap debridement group, you can see to the left the overview image. And here we have a proliferation of the epithelium. We have some bone formation in the apical part of the defect. But if you look at the high magnification to this area between the bone and the root surface, we have an interposed layer of epithelium. And the cementum regeneration is confined to the most apical part of the defect, indicating a rather reparative type of healing. Now, if I look at the defects that were treated with hyaluronic acid alone, what you can observe is a very nice formation of cementum, parental ligament, and bone. And you can always see the higher over the overview to the left, okay? And the high magnification in the middle part. So the overview depicts a parental regeneration. At the middle part of the screen, you can see the formation of cementum, parental ligament, and bone. And please observe, this is the first histology in an intra-bony defect that has demonstrated parental regeneration following the use of hyaluronic acid. And look at this beautiful histology with the investing fibers that connect the cementum with the bone. Now, if we combine hyaluronic acid with the collagen matrix, what we can observe is again formation of cementum, parental ligament, and bone coronally to the notch in the root surface that always indicates the most apical part of the defect. And in the middle part of the defect, we can see clearly the cementum, the parental ligament, and the bone that has reformed. And at a higher magnification, you can see the Sharpeye fibers connecting the bone to the root surface. And if you look now at the histomorphometric analysis, especially in terms of NC, this is the last line here, you can see that the use of hyaluronic acid alone, hyaluronic acid combined with the collagen matrix or the collagen matrix alone resulted always in a higher regeneration than the use of the control, okay? But even the collagen matrix had a certain effect in stabilizing the wound. And this is very important maybe for later clinical applications. However, all three groups that use the regenerative material perform much better than the control. And then let me share with you one of the last experiments that we published also this year, again by the same group. And here we had the question, what does it happen on a recession type defect? And again, in this study, we created recession type defects surgically, of course. They were chronified for a couple of weeks, and then reconstructive surgery was performed. Here we used a simple experimental design. The control was the coronary advanced flap alone, and the test was coronary advanced flap combined with hyaluronic acid, using the same product, namely the Hyadent that is a crosslink formulation. So please have a look at the different groups. Clinically, the healing was always very nice. And now if I look at the probing depth, and please observe, this is in this table, this upper line. If we add hyaluronic acid, we had roughly 0.5 millimeter or 0.6 millimeter shallower sites than in the flap treated group alone. Now, if I show you the histology, you can immediately distinguish the difference. This is the coronary advanced flap alone. What you can see to the left, again, the overview indicating some regeneration of cementum, peroneal ligament and bone, confined rather to the apical part of the defect. You can see some fibers that connect the newly formed cementum to the newly formed bone. However, if we look at one defect, one example of a defect treated with hyaluronic acid and coronary advanced flap, you can clearly distinguish to the left a higher amount of cementum, peroneal ligament, and bone, because the reference point is always the notch in the root surface, less proliferation of epithelium, and at a high magnification to the middle part, at the middle part of the screen, what you can see is the cementum, peroneal ligament, and bone that has reformed very nicely. So this is an example, again, of peroneal regeneration using hyaluronic acid, no doubt about it. Now, if you look at the cementum and the bone formation histometrically, please have a look at the difference between the test and the control group in terms of new cementum, 4.8 millimeters in the hyaluronic acid group, roughly 3 millimeters in the control, that means coronary advanced flap alone, and this is almost a 2 millimeters difference. Histologically is a lot. And if you look at the formation of bone, please observe roughly 2.2 millimeters in the test versus roughly almost 0.9 millimeters in the control, and this is more than 1.3 millimeters. So that is, again, histologically a lot of difference, indicating that we may obtain peroneal regeneration following the use of hyaluronic acid. So my conclusion is very simple. You can see it summarized in one line, 1.5 lines. We can say nowadays that endogain or enamel matrix proteins are an excellent material, very well documented, promoting peroneal regeneration, no doubt about it. However, the newly formulated hyaluronic acid, the crosslink formulation, seems also to have an important biologic effect And first preclinical data, we have a lack of human histology. I have to say it critically, but the histometric analysis and the histologic data demonstrated also prompt regeneration following the use of hyaluronic acid in intra-bony defects and in recession type defects. And with this, dear colleagues, I greet you from Switzerland and hope to have a very lively live discussion. And I'm looking forward to your questions. Thank you very much.
Thank you, Tony. Beautiful presentation, concise and very nice on the point as always. I've learned a lot about you, in particular as you're mixing your milkshake every morning. That makes a lot of sense for me now. So thank you for that tip. Great. So wonderful. Congratulations to your work. Before handing over the word to Shahram, because we want to all conclude that in a discussion afterwards, Tony, I just have one maybe quick question to you, which also came up a little bit in the chat. For me, these two biologics, let's call them biologics, right, are different. I mean, one is more a growth factor, and one is more a mediator of healing, as I understood it. However, they seem to have a quite similar effect on periodontal healing. Is that also what you could support? However, are there different mechanisms, and does that make a difference for the clinical indications when you're using these two materials?
That's a very smart question. And of course, the data suggests that also, I mean, with Emdogain, we know that we have real, because it is also supported by clinical evidence from long-term studies, meta-analysis, whatsoever. So Emdogain has a very strong activity, kind of is in fact a growth factor that acts on periodontal ligament cells, also to a certain extent on bone cells, but mainly on periodontal ligament cells, inducing even hard tissue formation and mineralization. However, if we look at hyaluronic acid is not a growth factor, but is, I would call it a rather modulator of growth factors. We know that growth factors act or have a stronger activity if a lot of hyaluronic acid is there. So what do we have in a wound? In a wound we have blood, and in the blood we have all the growth factors in a healthy person. So what we know nowadays that hyaluronic acid is a hydrophilic molecule, and in the very moment when it is applied in a wound where you have the blood, it attracts one molecule of hyaluronic acid attracts roughly about 30 to 50 molecules of water, a fluid, and of course it attracts the blood, and it seems that it may stabilize the blood clot, and of course you have the growth factors already there, and then probably this could be one of the mechanisms that I could imagine that may lead to periodontal regeneration. And however, if you look at the in vitro studies that we had, then we had also direct effect on periodontal ligament cells and on soft tissue cells. Interestingly, the main effect of hyaluronic acid is not on hard tissue cells, not on osteoblasts, because it doesn't induce mineralization. It rather maintains the stemness of the osteoblasts that may differentiate in different areas. But the main effect is on soft tissue cells and on periodontal ligament cells, okay? So that's why I think that the primary indication should be rather periodontal regeneration and maybe recession coverage. This is what we see also in the clinic. And of course, we have more or less the same indication also for Emdogain. We have to be clear on that. Okay, but we can discuss the pros and cons later on.
Andrea, if I see your face here, just a very quick question with a question for a very quick answer. If you do a recession coverage tomorrow, are you unboxing animal matrix derivative or are you unboxing hyaluronic acid?
Well, it will take a little more time, but we are after what Tony has talked about, the biology that is behind both of them. I think that he's right. The soft tissue is more prone to understand what's around when is hyaluronic acid implied with that, because hyaluronic acid is everywhere where cells have to migrate and crawl somewhere and regenerate. It's not something that has to do with a growth factor, but tissue um, growth needs HA ever since a human body starts from 2 cells up to 9 months of gestation. And here's where we find a lot of literature there. So I don't know, it's my time, but I think we should move along and see what the clinical issue is about.
Yes, thank you. No, it was just to always make a little bit the clinical transition. We'll see much more of you later. Shahram, it's our pleasure to have you here. We talked a lot about hyaluronic acid. We talked a lot about animal matrix derivative. We didn't talk about blood-derived growth factors. Now it's on you to give us your view. What is the backbone? Do we also see soft tissue speeding up? Do we also see an effect on bone? Shahram, it's our pleasure to hear your scientific content on the field of biologics with respect to bone-derived products. Shahram, please. Microphone.
Yeah, thank you a lot for this kind introduction and a very nice lecture, Tony. Congrats. And I'm happy to have you year round from all over the world. And actually, my topic will be not talking about the periodontal regeneration, because it's obviously, as a maxillofacial surgeon, it's not my daily routine. But what I would like to talk to you today is the role of technically what happens in the fact if you pull out the tooth. And I will then conclude why we would need PRF for that. Okay, so but just listen to the thing that as the tooth is gone, the bone will be technically going step by step in atrophy. That means if the tooth is available, there's a very nice metabolic active bone around the tooth. However, we know from a very nice study which was published actually 2003 in dogs, showing that having extraction, it could result in a very severe bone formation already after 1 month after extraction. That means if you pull out the tooth today in animals, that was in a dog study, you would have the highest range of bone formation after 1 month. And starting with this time after, it starts to become an atrophic condition. What I'm trying to tell you is each time we extract the tooth, we would have definitely a huge loss of bone. That's the reason why preserving the periodontal, let's say, tissue and everything around the tooth to keep it maintained would be actually very beneficial service to the patient. However, we have to realize that we have two components, which is a bony component and also a soft tissue component of the let's say, call it socket or the ridge. And accordingly, those two undergo an atrophy. And what I'm trying to highlight today in the last 5 minutes that I have remained, if we keep to the plan, is that we need the blood, and we need technically the blood drive factors, because we have everything in ourselves, and it's in the patient, because as you know, we are able to extract the inflammatory cells. We are able to extract the plasma from the whole blood, like to remove the reddish part. And we have a plasma which is actually containing not only the cells, but also the growth factors. And you will see at the end of this part how important that is to even support the patient in order to have a good quality of plasma, because it's more or less over 90% of the plasma is containing water. That means the dryness of the patient, and actually the amount that is drinking is crucial for the quality and from the agility and mobility and vitality of the cells and the growth factors. That means I would rather work on the blood concentrates and increase the plasma, the thrombocytes, and the leukocytes within this PRF, which can be gained either solid or liquid, and then try to find out whether it's somehow helpful to use it for the patient and to use it actually as something for its bone and also tissue regeneration around. What I'm trying to highlight here, we would need actually ideally it would be better not to have every few months a new protocol. That's the reason why we have established this so-called LSCC, low speed centrifugation concept. That means we have the same time, which is 8 minutes. And we have actually the reduction of the G-force, which actually is expressed by the rounds per minute. And you will see at this part, and then the second part, why it is important to have a systematic approach of let's say PRF, because in this way you are able to have an indication-based application of this blood derivatives. That means you are able to have a solid, but also you are able to have a liquid one. And if you have a liquid, like you can see here, it is rich of cells and growth factors, and it can be definitely used for also periodontitis or periimplantitis, and but also to treat chronic wounds and a lot of pain reduction, which is actually associated with our dental treatment every day. And to make it short, it is possible to have from the same blood either solid matrix or a liquid matrix, and this would be comparable, let's say, from the consistency and also from the application manner to that what maybe Emdogain is doing or giving, or actually even hyaluronic acid, although they are only one product or one item of which is influencing the wound healing. However, here we have a cocktail of all the goodies that patient is technically can deliver, and we can encourage the patient to live healthier and to live better. That means besides the fact that you can have solid structures, we have been looking at the growth factors and also actually components within the exudate and also within the liquid PRF, and we have seen that we have a large number of several growth factors that are definitely contributing to the tissue formation, to some proliferation of the cells, for the cell-cell communication between the mesenchymal cells and endothelial, but also epithelial cells. In other words, we are having a, let's say, a complex, which is the thrombocytes, which actually release the growth factors after aggregation. We have a large number of plasma proteins, fibrinogen. We have the immune cells, which we need for regeneration, specifically monocytes and neutrophils. And as you can see here, they also contribute to the bone, but also soft tissue, and also to the periodontium therapy, actually the tissue regeneration. In other words, we already have a natural drug delivery system, and it is, to my mind, a very good option to use it as also for the treatment of the session of the topic of today. And what it does is actually, it would help you to overcome the phases of the wound healing, which are actually usually going after each other. If you contribute PRF, liquid or solid, to the wound, you will see that the phases of the wound are going in parallel instead of after each other, which again means that you have a great and a fast and also a very sophisticated tissue formation. So these are actually the publications on it, but I would like to show you maybe with 3 more slides the eminent importance of treating the patient in order to make them strong for the let's say for the concentrate that we want to see. We know that vitamin D is a very crucial protein. Let's say it's a hormone, actually, it's not even a vitamin. And we know that we don't have a very sunny, unfortunately, daily life every day as you are working in the clinics, but also the weather is not in Europe, usually not every day sunny. And we do not take that much of exogen, let's say, input. So we would balance that. In other words, we are lacking of a huge vitamin D deficiency worldwide, as you can see here by the red and yellow part. And you can see that vitamin D is active in many cascades, in many different vitamin interactions. It is actually working with a lot of different substances and proteins, and it's responsible for many gene expression. In other words, we should actually take care of our patient, because if we are helping the patient to have a good vitamin D level, they would have also reduced periodontal disease from the beginning, and then we can discuss which would be the best treatment option to treat them. But first we have to make prevention, and for doing prevention, we know that even in medical staff, unfortunately, we have a huge deficiency. That's the reason why we have established, let's say, a protocol which says that you take the blood of the patient, and there are 3 options: either less than 40 nanogram, or more than 40 and less than 80, or above 80. And in these cases, you give either 10,000 a day, or 5 or 1,000 a day, and you measure after 3 months. And as you see, the patients are either in the same level, in the same range, or you have to adapt. And in this way, there will be no intoxication and no severe or actually any harm to the patient, but you help them to increase its regenerative potential. Of course, also for the periodontal treatment, which is a crucial treatment in order to preserve the tooth. So actually, this is the part that I had. It was a little rushing through it, because I think we should keep all in time. And I'm now happy for the next session.
Shahram, thank you very much for your nice presentation and giving us the basics of PRF and blood-borne products. Also giving us some ideas of what else could be responsible of healing or stimulating of the healing process. I just have one quick question before we move over to the clinical part, which is probably the even more interesting thing for the participants. We've heard, or we see that the effect of enamel matrix derivative or hyaluronic acid is rather in the early wound healing process. So meaning we see increase of vascularization in the first 3 days and 4 days, and there are some studies that there's no more difference after 7 to 10 days than anymore. Is that also the case for PRF, or in particular, maybe if you use membranes or something like this, is there a longer effect? I mean, I'm just thinking of, we see more swelling in these patients. So is there something you can say from your research or also from your clinical expertise, how long you think the effect will be when we use this product?
Well, this is a very, very good question. And we also know that the effect of this blood concentrates is remaining for the first, actually, up to 10 days. It's not a product, it's a matrix that is contributing to the tissue regeneration. So what we need here, we need an acceleration of the wound healing. But what I see, and this could be a very good option, and this could be discussed here also, I don't see a problem of mixing that with hyaluronic acid, right? So I don't see a problem even to combine it with even Emdogain, because these are targeting, let's say, agents for this specific type, but we are talking here the blood, and the blood is actually the source of life. So maybe this could be something to going to Andrea and Tony. We should make a clinical study and using that either in combination or actually in as a sole group, because at the end of the day, for me, it's important that the periodontal expert treats the tooth and tries to recover the tissue. And if they should use Emdogain, they should use it, or hyaluronic acid. But nevertheless, the patient should not be neglected. That's my main issue today, because we have to take care of the general and systematic characteristics of these periodontal diseases. And I'm fine with whatever it's used, but it should be taken care of the patient.
That is indeed a great point, Sharam. We always look into products as dentists. We always say we use this syringe, we use this syringe. But you're right. I mean, there's a patient hanging on the mouth, and maybe this patient has a bad lifestyle. This patient has low vitamin D. You're absolutely right, and we see this also in periodontal treatments. That lifestyle and general health is very important for healing and also for healing of inflammation. Thank you for pointing that out, and we will definitely pick that up in the discussion. We already have a lot of questions, and I definitely know we're not going to make all of these questions, but I'm happy to round that up with you after the last presentation. Thanks, Sharam. Just to make a little bit the clinical transition, I would like to give you just one case which maybe shows what it takes, or why are we talking about this, and where are the clinical applications. And I took a case where actually it is not about periodontal regeneration, it is about bone regeneration. It's something Tony has not addressed too much, because of course the research has been in periodontal regeneration, but I think some of the points Tony made are also applicable for bone regeneration, and I'm happy to discuss that with you afterwards when we also look at the cases. So let's look at a clinical situation like this, and I hope you can all see my screen. Of course, everyone is aware that there's a dental site here, and we have a bony deficit here. And if you look at the clinical situation, it's a classical lateral defect, which is a free end defect, and all of you who are experienced in bone regeneration, they know this is capable of osseous regeneration, but it's a difficult defect because of the anatomy. I mean, this is not a self-contained defect. And I would like to show you what I did in this case, and I have taped that as you see it here. I used DBBM materials, and I mixed it up with hyaluronic acid just to improve early vascularization. So my idea was always that definitely this bone graft will have a lack of vascularization. I mean, I think this is what we know from Vickers your work, that it's always a matter of diffusion into that defect. And I think this is where hyaluronic acid could help us. And I would be thrilled to know if blood-derived products would help us in the same amount, or animal matrix derivative would help us in the same amount. So what I did, I used a collagen membrane, as you see it here. I pinned that collagen membrane, and now I used that DBBM granules, which were impregnated with hyaluronic acid. As you see it here, they're just packed in hyaluronic acid, and I placed them into the defect. As you see it here, gently placed it into the defect, and by this augmenting the lateral aspect with this classical GBR technique. However, keeping in mind that this area will always have a lack of vascularization. So anything we use here concerning biologics will help us definitely. So then, okay, fixating the membrane on the lingual aspect. I think this is also one of the things Vickers showed us, that it is definitely a thing of how to fix these membranes. Coming back after 6 to 8 months, it looks like this, and I think we have a nice bony regeneration in this clinical situation. You can always judge that also by the pins that you see. You see the nice bleeding surface here, and if you now place your implant, it's definitely possible to nicely place your implant in a prosthetical driven way. And then, of course, soft tissue management, and we finalized the case as you see it here with the final prosthetic work. Interesting enough, we did a study on that. We compared lateral bone augmentation. It has not been published yet, so it's the first time I'm actually showing this work. This is also done in collaboration with Tony's group. We treated patients. We had different implant size. We had one group where we used DBBM particles with native collagen membrane, and one group was where we added hyaluronic acid. And we took biopsies, so we harvested biopsies and also looked at the rich dimension at the time of augmentation procedure, at the time of baseline, and also 5 to 6 month post. And interesting enough, that was quite astonishing for us. As you see here, the lines in the group with the hyaluronic acid, we saw better graft stability. We started from bigger defects, as you see it here in the blue line, and we ended up with actually pretty much the same amount of augmentation at the time of bone augmentation, and ended up at the re-entry with a better graft stability in that context. And that would make sense with what Tony said, is that probably also it has an effect on bone regeneration, and also has an effect on the collagen membranes, that it sort of slows the degradation profile. These were the biopsies. We did some descriptive histologies, and we always saw that the particles were better incorporated in the hyaluronic acid group. We also saw remnants of the native collagen membrane, which is quite astonishing after 4 to 6 months, but actually makes sense if we look into the work of Tony. So with just these few slides, I want to go back to us and introduce Andrea, who will hopefully take up my clinical ideas and give us some input on how we can use these preclinical informations on a daily basis. And this is already why I asked you on a Monday morning, dear Andrea, what are you unboxing? Because now we want to know all of this scientific data. What does it make for you as a clinician? So give us your view as a clinician on everything what Tony said in the beginning, and then we will also hear Sharam on his clinical applications of PRF. So Andrea, it's of course no necessity to introduce you, and it's my pleasure to hear your lecture. Please, Andrea.
Yes, thank you, Tony, Sharam, and Stefan, for your wonderful material. Of course, when it comes to talk about tissue regeneration and tissue repair, wound healing, everything related to histology, molecular biology, it's always useful for understanding what's going on in the clinical issue. And of course, I would talk about some more clinical issues related to both tissue regeneration, periodontal regeneration, like we can see here, where clinical several cases are presented here with infrabony lesions, and the same will be done for the mucogingival lesions or recessions. I always quote, dear Tony, your paper in 2015, because here you really presented what it's into tissue regeneration in human intrabony defects. And this systematic review goes really in detail what is useful from the laboratory up to the clinical aspects. And of course, I also quote several times this paper from Jay Perio that was asked to the Italian Society of Periodontology when they talk about the 5 different ways to regenerate the periodontium. And here, when it comes to EMD, amelogenin, of course, we know that, as nicely Tony presented, there is the lack of one of the most important tissues, which is cementum. We really do not know when we open a flap whether or not that thin tissue that is 50 up to 100 microns thickness into the mid-coronal part, whether or not is missing, is lacking. And the critical part in tissue regeneration is whether or not we're able to reconstruct, regenerate a thin tissue that harbors all kinds of growth factors, matrix components. And thank you, Tony, for what you've done in the years to give us the better understanding about this crucial tissue that comes from naturally from the cells that we know, mesenchymal cells that produce this important molecule. Enamel matrix derivative started with a case that Lars Sale, we know in 1997, showed us capable of showing histologically new attachment with cementum that is regenerated over the root surface, new PDL fibers, and new bone. And when it's into our hands, we know that a gel can become a potent stimulator for cells that are there, that are mostly in the PDL environment, and that in the end, in turn, will become clinical attachment gain. So we all know that this is possible. So cementogenesis has been explained histologically, not only clinically, that this is possible. We know that this can be done even without the addition of any implemented graft material. And in a few months, in a couple of years, we see that EMD, like we see in this case, is not only histology, it's not only molecular biology, but it's clinical gain of attachment. Again, thanks to Tony, we know another very important factor that we have to take into consideration when it comes to the efficacy of our biomolecules. See, here you see the application of the gel over the root surface that is being decontaminated. But we know from this paper, 2012 J. Perio, by wonderful people from Rich Myron to Tony Scullion, they told us that human blood should be kept a little bit away from the action of EMD. And this is something that we remember in our clinical use, because we do not only look at cementum, we look at new PDL, as we said, and we look at bone regeneration. Why hyaluronic acid? And this is important because HA has received close to 90 years of research from 1934. It's into the extracellular matrix for one important reason. When cells move, migrate, and tend to regenerate, they first of all have to communicate one another. And this environment has to be prepared for cells to communicate. We know this is a science. It's called cell signaling. Cell signaling is into the hands of biologists that know the cells communicate one another to then move and repair or regenerate. So when we look at a wound, as it was stated before, we would like to see those wounds that we do create with an incision, with cells ready to crawl, migrate, and for a closure and create a repair. And when is into this issue of cell communication, we know from recent literature that, for example, the two compartments, the epithelial compartment and the connective tissue compartment, meaning keratinocytes from the surface, fibroblasts down below, they have to communicate. In this drawing, you see communication, transformation of fibroblasts into some active cells called myofibroblasts that we in Sapienza really did investigate for their role, and the extracellular matrix. So the extracellular matrix functions as a world where cells can communicate, send themselves signals to do some change and then reach repair. So hyaluronic acid is into cell communication, first of all, and cell migration. So I personally have my experience, and I started in 1989 with my master thesis at UCLA investigating the bone side, osteogenesis, HA in vitro. And we found, for example, that low molecular weight HAs into intramembranous osteogenesis in vitro. And then the time goes by, so almost more than 30 years of research, and thanks to the help of wonderful people like Tony and Sharam and you, Stefan, we could be able to investigate and find out that, for example, HA has a bacteriostatic effect. It has an effect on calcification nodules formed from human periodontal ligament cell culture. Is like having in vitro a sort of cementogenesis. Again, pilot studies for clinical use, but most of all, let me jump into what I consider the most important factor in the clinical efficacy of HA, clot plus HA. What does it mean, clot? We know that a clot, blood into a level that is more prone to assemble cells and send information for bone regeneration is important, for example, with a mixture of the graft material. This is one of the most quoted papers, a review article from UCAN 2, that puts together different ways to regenerate periodontal tissues. But when it comes to the use of the graft, the clot plays a very important role into tissue regeneration. I'm not here to quote close to 90 years of research related to HA, but look at the most important ones. I mean, we find from very potent journals that the presence of HA inhibits clot lysis and in turn stimulates clot formation. So in one place we have a potent action for clot formation and inhibition of lysis. Again, many years ago, and this is found in very, very important journals like Science, for example. Let me quote this one back in 1965. And from that time to now, we know that HA has a role in increasing the tensile strength of granulation tissue formation. So protection of clot, stabilization of the clot, and increase of tensile strength. Science, 1985. Both you, Tony, and Sharam talked about the importance of angiogenesis. Angiogenesis is induced by the degradation of products of hyaluronic acid. And this has been proved by many, many other articles from 1985, from the 80s to now. So to make a long story short, we see HA in wound healing, starting from the blood clot, and also managing, regulating the inflammation, supporting communication of inflammatory cells, tissue proliferation, especially the low molecular HA, and final consideration into tissue remodeling and avoid formation of scar. Thanks to Tony, to Yoshinori, to my group in Sapienza, we then jumped into a clinical investigation study at 24 months with a randomized controlled clinical trial with HA comparing EMD. We found both treatments statistically useful when it comes to clinical improvements compared to with baseline. But what was very useful here is to initially, but then we found confirmed later on with mucogingival surgery that the patient side was very, very important, especially when we use the VAS analysis. So, for example, we would like to see the most efficacious type of treatment when it's into tissue regeneration for periodontal tissues, especially the combined type. Here's one of the many cases we treated together, and the group of in Bern run by Tony, that an infrabony lesion sometimes requires the help of soft tissue to, yes, help for the construction of calcified tissue and the tissues underneath, but also to recreate a better aesthetic for the patient. So here we have an infrabony defect with a furcation lesion of number 4, upper right, shrinkage of the papilla, some recession of the number 4, etc. What we emphasize is, yes, the decontamination of the root surface. We would like to only see the root surface, the bony area, and a reduced amount of blood in the area. But when it comes to the application of HA, actually, we know how nicely they play together. A few seconds after the application, for example, in the area, you see immediately, you can visualize a sort of meshwork. So the stabilization of the clot can be visualized by the construction of this meshwork, useful for cells to then crawl in the area and differentiate for tissue regeneration. So this is a combined single flap approach, combined therapy with HA and a graft material. Let me show you at 24 hours the wounds, how they appear. And at 7 days, this is a more in detail area of the releasing incision. So we see a very, very good quality of healing of the soft tissue. This is the X-ray at 12 months, the clinical image at 12 months, 18 months analysis, and the picture shows some root coverage, part of the root coverage of the number 4. The papilla grows coronally, little by little. This is a 7-year comparison between baseline and the final picture. The clinical, the probing depth, the clinical attachment gain. You can see now the patient after 7 years, and here's a video that shows you the closure of the embrasure, the almost complete coverage of the root, and the probing depth and gain of attachment. Is another case of a distal area of a lower left first molar at 8 years. Let me show you again the combined therapy with HA and the graft material, and the quality of the healing at 72 hours. This is what we normally see. And on the patient side, as I said before, is very important when we focus the analysis using the visual analog scale for patient response. This is very, very common when the use of HA is into infrabony defect regeneration. Moving to the mucogingival surgery, when we deal with recessions, normally called mucogingival lesions. Back in 2006, my great friends Paolo Camargo, the chairman of UCLA Perio, and Michele Paolantonio is the chairman of Perio at the University of Chieti, two giants in periodontology. We wanted to start looking at the use of EMD for mucogingival recession lesions by using the coronally advanced flap and EMD. And we found some increase of keratinized tissue at a 18 months clinical evaluation compared to baseline. And of course, from the patient side, consideration of the patient response, a great results. But let's move into the world of HA by recapitulating again what it does for the blood, for controlling inflammation, cell proliferation, and remodeling, including a huge topic, Stefan, that I will not analyze today, but it's very much into HA, which is the scarless healing, almost scar-free healing that is typical of hyaluronic acid. Again, thanks to my Swiss friends and my group, we have been able to publish this paper on single gingival recession sites, middle class 1, and with and without the use of hyaluronic acid. This is a perfect example. The root is really cleaned and decontaminated. Tissues are prepared and full split thickness flap to passively move coronally advance this flap. And before we do that, we apply our biomodulator, HA. And again, 1-2 minutes later, we see this very clear image of a meshwork created by HA and blood. So the two guys together work very well. This is the suturing, passive suture without tension, the before and after with minimal scar tissue formation. I would not say that this is here an example of increase of keratinized tissue, but this is something that is mostly seen in clinical use when it comes to recession types. Again, another case, this is the amount of root exposed with missing cementum, PDL, and bone. This is the layer of hyaluronic acid 1 minute after the application. We wait another minutes or two and see again the blood starts crawling inside like a sponge, because let's face it, HA is a sponge. So we remember that, we know that. The suture, the clinical appearance after 12 months. What we have found that is that when it's about recession depth, recession reduction, at 18 months, we've done this at 1.5 years, was higher the recession reduction for test group with HA compared to control. The KT, keratinized tissue, did not change for both types of treatment. Again, visual analog scale. At 7 days, we found a dramatic difference from patients with the use of HA compared to control. This is something that is important for us. We know that we would like always to be at patients' side. Single recessions, the same for multiple recession types. This is the application of HA. We have no problems in seeing the, let's say, contamination of the roots with blood, because they have to work together. HA in place. This is the suture in place. And again, another image at 24 hours. 24 hours is a time that we are investigating in detail in my group, and we have published recently molecular biology studies confirming that almost everything happens during the first 1 and 2 days. But for sure, HA gives us the idea that the inflammation is under control and wound healing is in a great shape, because there is a a molecule that is into wound healing. Final consideration for a non-infected bony defect. We published recently in Clinical Advances in Periodontics the surgical treatment of a segmental tear associated defect, where the use of HA and a resorbable collagen membrane to, let's say, protect the defect and in a way stabilize the clot organized by the presence of hyaluronic acid to a very interesting result. So not only for infected areas, but also for this type of lesions. And I am done with my presentation, making this conclusion. Thank God Stefan, you asked me some time ago what I think now. Well, thank you to this wonderful group of people, and Tony and Sharaman are there. We can explain both sides of the story. So we're happy for the clinical aspect. We're happy for the response of tissues of our patients. And thank you for looking into the GBR world, because again, the combination of HA and clot stability might really be a big difference, at least for the first part of the healing of bony defects like the one you have shown. But again, thank you to the effort of this wonderful group of friends, where we see histology, we see molecular biology, we understand cell movement, we understand cell differentiation, we understand what happens when we, lay down a gel that comes from a syringe.
Andrea, beautiful. Thank you very much. Beautiful presentation, nicely outlined, beautifully educated. Thank you, and I congratulate you to your work. Thank you very much. I'm a little bit confused now what to mix into my milkshake tomorrow morning. Tony said it should be animal matrix derivative. Andrea, I maybe doubt. Maybe it's going to be hyaluronic acid. Let's see. Andrea, I just have one very practical question, which also came up a little bit in the chat before I hand over to Sharam and asking him to show some clinical aspects. Tony has discussed about cross-linked and non-cross-linked hyaluronic acid, and we obviously have these two products. Just give us your clinical choice. Is that depending on the indication, or is there a personal preference you have?
No, actually, Tony always raised up important issues, and he's right. I mean, let's remember one very important thing when it comes to HA. HA is not the same every time and everywhere. The cross-linking means that, very simply, that HA can be more or less stable in time. The more you cross-link it, the more stable it is. So let's go back to your cases. I mean, you need the clot to work for a longer period of time. So the cross-linking there is very, very, very important. When it's about the 24 hours healing, let's say mucogingival surgery or any type of incision that requires very, very little time for the healing, you don't need to build up bone or cementum there. Maybe a less cross-linked HA can be useful. Now, where is the real one? In our hands, we have in the market something that cuts both ways right now. This is the beauty of what we have now. But again, Tony and you have raised this very important issue of what is into the cross-linking. And final consideration, for example, HA disrupts in smaller pieces. You go into smaller pieces from bigger ones, you have angiogenesis. So see, Stefan, it's like playing with something that works so well, but you have to understand how and where is the application and the understanding. So I hope to
So,
have
so
responded to
just in a nutshell, let's put it that way. The bigger the area of let's say non-vascularized tissue is, the more we would go for a cross-linking hyaluronic acid, and the smaller
right.
this area would be, we would rather go for this quickly resorbing material.
cross-linked enough, but not too much. Okay,
Got
so
it.
this is how we play with that.
Great. Wow. Beautiful. I mean, this is so much information. I mean, we get so many questions. I will wrap up some of the questions. Please don't be concerned if we don't answer your question. We will definitely find ways to send in the question to the panelists. With this, I'll hand over the word again to Sharam. Sharam, now it's on you to give us some clinical ideas. I mean, you talked about healing of PRF, you talked about a cocktail, but nicely also talked about the patient, which is probably the backbone of the healing. And it's not only the local things we do, but it's also the systemic application. I guess you will talk a little bit more about the bigger defects. The bigger the surgeon is, the bigger the defects are. So Sharam, please give us some clinical pearls, some clinical ideas on the use of PRF on a daily basis, please.
Very much, Stefan. I would definitely like to show you a randomized clinical study, which we just finished, and it's going to be published soon. And I think this will help a lot to understand what and in which sense PRF can be used or not. But before that, I think I read some of the questions about the vitamin D dose. So here's the publication that I was talking about. We just actually published that in the beginning of, right before COVID starts, or actually in the middle of in this pandemic thing. That means it could have been a very good help to stay healthy. So what, in other words, you just have to do your vitamin D testing. You have to take a blood test, and then you will see where you are. Either you are less than 40 nanogram per milliliter, or between 40 and 80, or above. In these cases, you should take either 10,000, 5,000, or 1,000 accordingly. And then you have to measure again after 3 months. I think that's a major part, because a lot of medical doctors are concerned about vitamin D overdose. And if you just follow this, let's say, concept, you wouldn't have no thing to worry about. But let me come to the presentation I prepared. Of course, for tonight, I will not be able to talk about all these clinical aspects that we are actually focusing on in the last about 8 to 10 years. So by now, we have been finishing more or less about 10 randomized clinical studies that will be published in the next couple of weeks and months and years. And here we are focusing on socket preservation, recession coverage, actually medication-related necrosis of the jaw, complex jaw reconstruction, which is my own topic, TMJ, periodontitis, periimplantitis, soft tissue, and sinus. That means there's a network of people which are together with me, and these are the group, and we are doing investigator-initiated trials. That means these are the money that has been technically given by agents and funding agency. That means there is no industry behind it, because as I said, PRF is not a product, it's a blood matrix. And I think the best and the most, let's say, the most convenient way of finding out whether it works or not is to have objective data rather than being focused on selling a centrifuge or device or anything. So here, there is no other message but finding out what is PRF doing. And for this, I would like to show you how we approach. And I'm happy actually inviting you to follow, because it will be a great pleasure to make the group bigger and bigger. But it looks like that. We do the tooth extraction. We are trying to allocate the groups, the control group, which receive nothing, the second group, which is receive a, let's say, solid PRF, which has 1200 RPM, 8 minutes, and the other one receives a liquid PRF, which has 600 for 8 minutes. That means, again, the time is the same, but also the RPM, accordingly, the relative centrifugal force is different. And what we do, we look at the X-rays after extraction. We do take care of the wound healing in terms of photo documentation, but also and finding out about the visual analog scale, how the patient is working. We do a CBCT before implantation, and of course biopsy by the time of implantation. And I would just like to share with you some of the initial data of that study. As I've shown you, more will be coming in soon. And this is an animation I did in order to make it for you easier to understand. Technically, if you look at the control group, you just pull out the tooth, there's some blood coagulum, and you see that over the time, we do not have a sufficient or let's say complete closure. This is how the pictures showed what we have then been analyzing. And in other words, we have after 10 days, almost 60% left. In the other group where you just use solid PRF, that means you take the red tube, which has glass tube, and you generate a clot. With this, you would actually have a plug, which is shown in this video also. So we are focusing on this part. That means you take the clot, you remove the reddish part from it, you press it to a plug, and technically you have it ready to be used in a socket, let's say premolars, for example, and then, or molars. And then you see that as you put it in, there is a, let's say, relatively spoken, a faster closure, because it is giving the soft tissue kind of a very nice pattern to grow on. It serves as a scaffold. Interestingly, if we use the liquid PRF, and that's actually the phenomenon that we were very wondering about it, that means if you just use the liquid without its polymerization to clot and do the, to have a liquid matrix, which would be, let's say, comparable to what we are talking about tonight, like like Emdogain or hyaluronic acid as a cocktail. The funniest and the actually very important part is we have even actually almost 100% closure. That means there's inside something that helps the soft tissue actually to close fast, and in order to enable technically the bone tissue to come back. And this is how it looks from two-dimensional. So all of them received a suture. That means we kept every single step equal. One is nothing, the blood, one is solid, and one is liquid PRF. You see that as the time starts, the groups in the PRF start, actually the soft tissue starts to kind of grow towards each other. This is already after 1 day. And after 3 days, you see that in the solid, but also in the liquid, you see a nicer and a faster closure comparable to the control group. And now see what happens here. As it is not closing fast, it will be technically gone, because it will be undergo dissolution by the soluble factors of the mouth. And in other words, we have after 1 month this status. We have a, let's say, invagination here. We have a rather nice closure in the two other groups. And if you look at what happens after 3 months, and that's actually the very phenomenon interesting part, we see an atrophy condition here, a less atrophy in the solid one, but also more or less no atrophy in the liquid one. In other words, these are the histomorphometric data. We see that the liquid has a nicer and a faster closure, but I would want to show you again, and actually this is the main message of my talk today. There will be an atrophic condition if you do not load the bone, either by an implant or if you are not able to regenerate the periodontal, let's say, tissue to maintain a collaboration or say a continuous exchange with the surrounding bone. And in this case, and if you even use PRF or EMD or HA, if you do not use anything that remain or keeps the volume in a way you like it, like Stefan showed one case where he used, I guess it was a Senogenic product mixed with HA. That means do not believe that either of these factors are permanent placeholders. No, we really need still, let's say, bone substitute material. We need placeholders. We need actually cages and so on and so on, that I do not want to discuss tonight because it is, I think it's more focused on periodontal treatment. And I'm happy to actually answer you any other question if you have tonight or later on. And yeah, I think that was a contribution to show the clinical benefit of PRF, specifically the liquid, but also the solid. And I think it was important for me to show you that you should, again, focus on the patient, because the better the patient is drinking, the better it is actually having a very good vitamin D value, the better the nutrition, the healthier he is, and the healthier it will be his treatment, but also his blood will be contributing to a better and healthier outcome. So thanks a lot for your kind attention.
Shahram, thank you for this nice clinical presentation. Just one question before we go into our round of discussion. There are so many formulas over the last decades when we talk about blood-derived products, which, to be honest, actually confuses me. That we have PRF, we have LPRF, we have PRGF, we have PRP. I mean, just give us maybe in some sentences, what should we know about this? Why is there this kind of evolution, and where are we today? I mean, you're talking about the low speed process, which you're obviously looking into, and why is this beneficial? So just, I think for everyone to not be confused with these products, which are great, just give us a brief evolution and where we stand today and what we know about this.
Well, you know what? I'm really thankful for this very nice question. And let me just go back quickly to this slide, and I show you why. See, this is exactly what you say. We have different P's, I, L, whatever. I think the problem is that some of the people are trying to take advantage out of people's knowledge or unknowledge, and by coming on the market with any centrifuge, they try to, of course, to have a different, let's say, protocol associated with that centrifuge because they want to sell. And what we did here, and actually this is what I did, and this is also different from what Joseph Chakroun is doing, I think it is possible to focus on 3 standardized protocols that are able to be obtained on any centrifuge in the world, which are programmable, you know? And these factors, these 3 components are actually a setting that are not related to any company, to any centrifuge, to anything. And we have high, middle, and low speed. That means we were able to find out, and this is what we need, Tony, and we just have seen a lot of nice data about so many nice HA papers, or actually also so many different you know, Emdogain papers, because people are focusing on that. But we will never have data if we come up every 6 months with a new protocol. That means at one point we have to start to realize that we should have all the same goal, and we should focus on systematic approach on the centrifuge, no matter of their factory name, and try to find out how these cell components or blood concentrates are contributing to a hopefully better outcome in a surgical routine that we have. So this would be my answer for that.
Thank you, Shahram. I think that clarifies a lot, and we hope with the group you established, we will have much more clarity in the next 5 or 10 years when we look into these products. Maybe Andrea and Tony, you will come back to us with your beautiful faces, and hi guys. Let's settle into the discussion a little bit, and we have a lot of questions, and definitely will not be able to answer all of them, and I would like to just sort of make one path through it. And I think one thing which should be important is we talked a lot about periodontal regeneration now, and I think we heard different aspects from Andrea and from Tony. We haven't talked so much about true bone regeneration. Merely the case I showed, something like this. Maybe just from all of you, Tony, Andrea, and Sharam, how would you rate these biologics in terms of bigger bone augmentation? So meaning not tooth-derived things, but probably in the edentulous areas. So how would you rate that? Are these materials also capable of regenerating or helping in regenerating these bigger bone defects, or is there something where we should rather go to the blood cocktail Sharam said, because we have interaction of more growth factors? So all of you three, give me your clinical and your scientific take on that, and I will start maybe with Tony because you had the first presentation.
I think that's a quite important question you raised. In my opinion, if you look at the data from the literature, I would primarily use the two products or the two concepts on materials, enematics proteins and hyaluronic acid, first for periodontal regeneration or soft tissue wound healing, soft tissue regeneration. Regarding bone regeneration, if you don't have teeth, I don't think that these products will promote bone regeneration. I mean, maybe to a certain extent, we have to be clear on that. Of course, we will have a better or faster soft tissue healing, which indirectly will affect also the bone regeneration, because if you have a very nice wound closure, then of course the bone underneath will reform much faster and much better, but it is not primarily on the osteoblasts. The second aspect is maybe also the clinical applicability. So if you mix, for example, Emdogain with a bone graft or hyaluronic acid with a bone graft, you can handle the bone grafting particles easier, and you get the so-called sticky bone, but probably you get the same also with a PRF. But in my knowledge, if you want to have bone in big defects, you need to have BMPs. Huh? We don't have to talk about the near the line. I think if you have to want to bone, you have to have BMPs. If you don't have BMPs, the rest of the growth factors mainly affect soft tissue healing, huh? And that's it.
But that could help too, right? In bigger defects.
Of course, yes, of course, but not primarily on the osteoblasts. As I mentioned before, you have a very fast and inflammation-free soft tissue healing, and if you have a very good closure of a defect, a secluded space, of course you will have a better bone healing. And then you have the practical aspects. A certain effect on bone cells you see with Emdogain, but whether this is clinically relevant or not, this is still a matter of debate, and until now nobody has proven a real benefit of Emdogain in purely bone defects.
So you're saying the backbone of this mechanism is the influence on the periodontal ligament cell?
For sure.
Okay, great.
And also on connective tissue cells. And of course, if you have a flap, you have connective tissue cells in the inner side of the flap.
Great. Andrea?
Well, to make a perfect example here is to say that if you look at the human body in the adult, we do not find HA except for the humerus vitreous and the PDL. So PDL was considered in 1988 by Newman and Berkowitz a fetal-like tissue. So it's interesting what Tony has said ever since he started. I mean, here we have a recapitulation of fetal-like tissues, fetal-like tissue, the PDL, that is the only one except for the eye, the vitreous, with a huge amount of HA. And why is that? I mean, we need cells to be in a perfect environment to communicate, and regeneration is always there. I mean, a tooth, I'm not saying it regenerates every day, every minute, every second, but it's a place where tissue regeneration takes place many times in even in health. So I quoted the Tony Sculian 2015 paper on Periodontology 2000. He says, well, if you take a graft material alone, doesn't do much. You need blood around, you need cell movement around, you need cell communication. I mean, there you see that blood is crucial, is central. And when it's about bone regeneration, why not? I mean, bone comes from blood. And it's not a matter of growth factors, a matter of all these things that we said, including the fact that when it's about regeneration on root surfaces, PDL starts from an HA-rich environment.
Great, thanks. Shahram, what is your take? Do we see an effect of PRF on soft tissue healing, and does it just help us? Or is there a true effect on bone regeneration also in the edentulous defect?
Well, we have just actually successfully passed the guidelines of S3 guidelines 2 weeks ago, which was organized by the German Society for Implantology. And I had the honor to be the main responsible person. And we have now evidence that PRF actually is supporting the soft tissue closure, but also the volume maintenance of the ridge. However, I fully agree to what just Tony and Andrea said, and we have to focus on surgical approaches, flap bracing, regeneration, you know, as you said yourself, to look at the side, what we want to see in an edentulous patient and which dimension we want to augment. And I do believe that it is a wrong message and a wrong direction if we tell that people either mixing that with PRF or HA or Emdogain will have necessarily better bone. We have to show that. We don't know it yet. But for me, at the moment, we should accept that it has a very main, let's say, working area, which is in the periodontal tissue. But for bone, I would be a little bit more, let's say, you know, it's not too impulsive and not too over exaggerating, because we need to have randomized clinical trials to find out whether at the end of the day, mixing that either with one of these three candidates is better than not mixing that, or it's actually equal to mixing that only with the blood, which we have in a surgical field anyway. In other words, we have to show that and we have to see that. But for sure, and this is again what Tony also said, we will have a faster soft tissue closure. And accordingly, we will have a better condition for the bone below to grow. But I do not see necessarily a direct influence on the bone. And here again, Tony, I agree, we would need some BMPs, which we don't have in none of them. And we have to be fully, you know, like realistic. We do not have to overpack it, because it will become like a phase and we'd go away. I'm happy that we have those biologics. We have to learn to deal with it. But to everybody outside who is now listening and watching, as I said, and I repeat myself, the correct treatment of periodontal patient, the systematic analysis of their medication on their diseases, the patient itself, the anamnesis is at least as important as putting something in between the tooth and the bone in order to try to heal it. So do not neglect the patient again.
But friends, don't be so pessimistic. I mean, for me, if I look into bone regeneration, I mean, the main complication we see in literature up to 50% is wound dehiscence and leading to failure. So, I mean, if we now agree that all of these biologic agents we talk about can possibly improve early soft tissue healing, I think that is great news also for bone regeneration, meaning that we may be capable to limit our soft tissue complication. I think that is at least what we can state here. Could you support that, or is that just too far?
Who wants to start? Tony or Andrea, go ahead.
No, I just want to make a final comment here. I agree with all of you. What Tony said, when you have a primary closure, I mean, that's a perfect time zero for perfect healing. And that's in the hands of a skilled surgeon. No matter how brilliant is the molecule there or intelligent growth factors you place underneath, I mean, let's face it, we are surgeons, and we first of all have to know how to perfectly manage soft tissues, because then whatever you apply into your regenerating area, and of course we have intelligent and smart molecules that will function much better. I mean, we should not forget that the very first enemy of cells are the bugs. I mean, we are in the era of viruses, but we never forget how bugs interfere with the wound healing. So the better, I agree with Tony and Sharma, the better and the faster the wound closes, this is HA, for example, even EMD, the better it is for the rest.
Okay,
yeah, I think we should definitely use this occasion like tonight, and we should really think about to systematically go for different indications and find that out. And it doesn't have to be that it is bad to add it. It just have to be shown in which stage it might be better or not, because in this way, not only the doctor who is using that, but also the patient will gain more confidence. Because if we do tell that using whatever of these 3 agents is now better than not using it, and if it still comes to a failure, that can happen because of the skills of the surgeon, then the patient think it was this product, which is again not fair to the product. So I think this is the main message of all of us tonight, of all of us for using any biologics, whatever it is, either as a growth factors or promoter or blood or whatever, should not be so seen as this own very component and neglect all the other items. Because in the surgery, you have to come to your learning curve, and you get it by doing cautious and step-by-step, like surgery. But in other words, I agree with you. Having that helps to better closure and to better soft tissue. And accordingly, we will have better outcome in the surgery, which is a beneficial compared to saline. So I fully agree that it's good to have one of them, but we have to find out which one eventually would be the most, let's say, this one factor or component serving for the bone. But again, neglecting the fact that it's working very well for the let's say, periodontal tissue.
I think that one important point is to mention that the highest concentration growth factor is definitely in the PRF. I mean, there's no doubt about it. And if you have the possibility to use it and you are skilled to use it and you implement it in your practice, I know many clinicians who are using it with excellent success. So probably in terms of growth factors and autogenous growth factors, PRF is probably the best among all these products. But of course, you have to take also to look at the other side of the road and to look at the normal dentist who maybe is not willing to routinely use the PRF. So I think for smaller defects, using hyaluronic acid, taking it from the shelf and having an excellent outcome is very good. And for periodontal defects, definitely Emdogain is also a good option. But if you would look only biologically in the lab at the concentration of the growth factors, then is no doubt that PRF is number one. Huh? I mean, we don't have to speak something that is, I mean, not realistic. But there are also some other aspects. In some countries, it's difficult to harvest to take the blood if you're a dentist, or there's also some legal aspects, et cetera, et cetera. But if you look at the biology, it's definitely something that may really be a game changer. And especially, I think that if you are dealing with immunocompromised patients, then definitely I think that PRF can improve the wound healing. If you have a diabetic foot, for example, we have wonderful data from Nelson Pinto with really huge wounds that have closed just due to the treatment with PRF. I think this is unique in the medicine, and we do not need to have to focus only on 2 millimeters of probing depth or a pocket, but probably there are also more important indications in medicine than that.
Great, thanks, Tony. I think that also answers the question from some of the participants. Can we use it around implants? Can we use it for peri-implantitis and so on? I think it is the same answer. It of course, well, we know it speeds up soft tissue healing, and of course, primary closure helps you in every kind of defect. I have a little bit of more a practical question, which also has been raised a little bit in the chat. Tony, maybe that comes to you first, and then asking all these others. In the earlier times when we started with Emdogain and animal matrix derivative, the protocol was very important, like having it very dry. I remember us having a gauze pack packed into the defect and then removing it because it has to be really dry, that it really is placed on the root surface. That hasn't been addressed too much from all of you three. So it just seems like a topical administration in the wound of these materials. Is that true? Do we need to do we need to consider protocols, or is it fine if we have like a topical application into the wound? Andrea, maybe you can also elucidate a little bit on your idea of waiting for some minutes, as I understood that, but maybe Tony first.
Definitely, but I think that Andrea very nicely mentioned the paper by Rick Myron, you know, with the interaction with blood and Emdogain. So this was, in fact, one of the reasons I started to use hyaluronic acid, because I do quite a lot of tunneling approaches for recession coverage. And I used routinely Emdogain, still use in very deep recessions. But what I observed is that all of a sudden, after the application of Emdogain, the blood or the bleeding is difficult to be controlled. And I had the feeling as a clinician that everything is flushing out of the wound. And then we did also a study that has been published, and now we look at the 5 years data, that in fact the combination of Emdogain and the connective tissue, when we use it in as a tunnel approach, was not necessarily better than the use of connective tissue alone when I used the tunneling approach. And I was wondering what was the reason for that. And of course the connective tissue is very important, but maybe I was thinking that it could be that the Emdogain was not any longer in that concentration in the wound due to the bleeding that you can hardly control if you tunnel. If you have a coronary dense flap, then of course you can dry and then you place Emdogain and you replace it coronally. But if you have a tunnel, it is much more difficult to control. And we also looked at the first healing phase, took some samples from the wound, and wanted to detect Emdogain immunohistochemically, and out of, I think, from 20 samples, we were able to detect it only in 5 or 6 after a couple of days, or even earlier, which may indicate that there were hardly rests of endogain there because due to the bleeding they were flushed away. And in fact, that is the advantage of hyaluronic acid, because I don't care whether it is bleeding. We know that if it is bleeding, hyaluronic acid acts even more efficiently. So from a technical and biological point of view, for this specific surgical technique, I think that's this is a very good material and a very good product to be used.
Thank you. That's a great clinical experience. Andrea, is that also your experience?
Well, Tony said everything, but just to go back to one does not fit all. But for sure, one fits one and the other one fits two or three. For example, let me go back to the embryo. I mean, if you look at the early stages of an embryo and that becomes a fetus, you see that the embryo is like a huge sponge of HA for soft tissue growth, but also bone growth. Then at the end, everything is, you know, assembled, and you have 9 months later the final product ready. I'm not saying it fits everything, but for sure, when it comes to soft tissue, for example, the cells, in order to close the wound, they have to detach. Cells to in order to close the wound and migrate, they have to detach from where they are from. And one of the peculiar mechanisms of HA is the detachment of a cell. So I'm not saying that one fits all, but see, this has nothing to do with the EMD. When it comes to create cementum, EMD works very well, but we're there to do a little bit more than cementum. And unfortunately, we are dealing with 3-4 tissues. I mean, PDL, cementum, bone tissue, and other two, epithelial cells and connective tissue cells on the flap. And going back to the fetus or the embryo, it fits all because it goes there to help almost everything. I'm saying almost because I agree with Sharam. I mean, we're not there only to look at biomolecules. We're there to, and again, what Tony said, in a specific area, we have a small defect, we have a defect around the root surface, we have a bigger defect that has nothing to do with teeth, but has to do with a reduced vertical height or horizontal width of a crest. It might fit better HA, but it all is connected to what we are utilizing, we are doing. PRP, PRF, I agree. I mean, you need more there, and they are very helpful. So I don't know if I explained, but we're not, again, to help the dentist say, take one and you do even a composite resin filling. But it's something that we have to sit down and play, being strong from the literature. But again, with HA, it does not fit all, but at least fits 2 or 3, okay?
Sharam, is the protocol depending on the indication?
Well, yes, because Sony said you cannot use EMD at all in the presence of blood. I mean, it's not the fault of anyone. It's an issue. It's a fact. EMD has to transform mesenchymal cells into pre-cementoblasts, cementoblasts, and cementocytes. Period. If you put it in culture has to be the same. You do not add blood on top of the dish, right, Tony? You see cells differentiating in the absence of blood. With HA, it's different. You have to add blood there. So the protocol has to be connected with the logic of the action of the molecule.
Yeah, I agree.
Sharam.
Yeah, but you know what has been before, and this is a very important aspect. I mean, we are sure about that all of the 3 agents, let's call it agents, are making the bone substitute material more sticky, right? And
Exactly.
as it is more sticky, it is nicer for the doctor, for the surgeon to play with, to place it, to form it, it does not get lost in the suction or wherever the
Right.
mouth of the patient. So this is a very good beneficial. And I really agree if you say some doctors are firm in taking blood, some others do not know it, or some other never learned it, or some other forgot how to do it. And maybe they should go and for this biologics to take out of the shelf. I really think it's okay. But what I do not want, or what I would like to propose, is not to hype some of them, neither of them. If you too hype it, then there will be a huger and a faster disappointment, and then the whole concept of biologics will again be put under question. So I think, and this is exactly what we three said today, if we go for indication, you have indication for this, you have indication for that, you have indication for none of them, you have indication for something else. I think this should be our target. But for sure, as an expert in periodontal treatment, as my colleagues are here, they would say using for deep defects, Emdogain would be beneficial if you get it inside without, let's say, bleeding. And they say also in smaller defects, they would recommend to use HA, right? But again, from the perspective of what is inside, we have the most in PRF, but we don't even know that how much is needed at the moment. Even this we don't know. We don't know how many thousands or millions or cells of growth factors we need for a wound to become better or less. So I think we could be happy that we have today the focus on biologics. That's a very enriching component because it's not one bovine or porcine or whatever product. It is, let's say, a concept. Hyaluronic acid is a molecule that is part of the body, and so Emdogain and so PRF. And we should learn to, let's say, when can we use it alone? Where can we use it with different, let's say, collagen membranes or bone substitute materials? But as I said, at the end of the day, we have to deliver the data, and everybody who does clinical studies knows that it's very long lasting to get this data. But eventually we will have it, and we will hopefully see each other again at some other occasion and discuss that and publish that and gain more. So I'm confident that it's good to have biologics in surgery, but I'm sure that it's not the right moment to push and hype them too much because we don't have data. I think, to be honest, we have data for this specific indication of periodontal treatment tissue, but we don't have a broad data of HA or Emdogain in so many, let's say, separate bone defects, nor do we have for PRF. And we have to be step by step going and be patient. This is my opinion.
Okay, friends. I want to ask one last question. We still have a lot of open questions. Some of them are really detailed. So we're going to manage that everyone gets an answer. So I have maybe one final question. I already heard Sharam is quite hungry, so I really want to get you into dinner, Sharam. Just one final question to all of you, which is for me an important one, because we discussed about the effect of all of these agents on the soft tissue compartment, meaning the periodontal ligament cells, but also the connective tissue cells. We saw some publications, in particular on animal matrix derivative. I think of the Hegerwald paper. We saw some publications on PRF or blood-borne products from Bauer's group, seeing soft tissue thickening after these therapies, after a period of time. So we saw Andrea showing a recession coverage in a thin periodontal biotype without adding connective tissue graft. So is that something we see with this product? I mean, I'm not talking about 2-3 millimeters of thickening. I'm talking about 0.5, 0.7, which could help us as a clinician. So is that something you see as a clinician, that we will see soft tissue thickening over a midterm, which could definitely help us in a periodontal recession coverage case, but also in in a bigger soft tissue case. So that will be my question, maybe starting with Andrea, because you showed some of these surgeries in rather delicate soft tissues, not grafting it with connective tissue. So do you expect a soft tissue thickening over time?
Well, I personally did find cases where some thickening of the, or if you want to call it the increase of keratinized tissue around teeth with the use of HA. Okay, I'm relating to HA. But then when we look at our data, the study we published with Tony, we didn't find that. Okay, so in my opinion, I would not expect from HA to increase any thickness. But for sure, to move keratinocytes and close, I mean, the environment in 24 hours, 48 hours better than control, of course, I would expect that. Because I personally, I'm convinced that when it comes to thickening of tissue, there is also very much individual response involved with that. Giovanni Zucchelli talks all the time about areas of the palate where you harvest, for example, the back area of molars. You use those for root coverage, and you might see some keep thickening of the tissue. We don't know that, but I think that it's into the individual response more than that the molecule. But when it comes to faster closure, yes. I mean, keratinocytes have been, we have so many papers that have shown that. Keratinocytes, they fly over HA. And those are the cells, the first layer that are into the wound healing.
Thanks. Shahram, do we see soft tissue thickening over time in PRF cases?
Well, it depends on which indication you're talking about. But let's say we can say that you see a maturation of gingiva, which contains keratinocytes, but also fibroblasts and connective tissue cells. I think, yes, we could say we have a maturation. And if this is soft tissue thickness, yes. But again, as we also mentioned again, and this is something that I also am observing the last 10 years now that I'm working with blood concentrates, we have to look at data also some years later, not only at the second that we do the operation, but again, in many cases we have in relation to the surgical field, if we do, or if you're able to operate without retractions and without too much tension, we will maintain the results for a very long time. However, if we close the flap with a huge power and strength, although it looks nice at the beginning, it will undergo an atrophy in the meantime as the bone is gone. In other words, I think, yes, if you maintain the volume of the bone and the soft tissue, but no, if you just think that's the only solution.
Tony, any soft tissue thickening, maturization, keratinization over midterm in cases with enamel matrix derivative?
I think that for that we have to look at the old study of Andrea, where he performed coronal advanced flap with and without Emdogain, one of the classical studies on Emdogain for recession coverage. And after 5 years, if I remember well, you have had not only a stability, but even a certain increase in the width of the attached gingiva. And the same has been also proven by Axel Spahr and Stefan Hegewald in one of the earlier studies in 2006. They were published in 2006. So I think we have it, definitely. And regarding hyaluronic acid, we don't know because until now we don't have long-term data, but Andrea has a nice study where he compared coronal advanced flap with and without Emdogain up to 4 years. And it seems that the results are stable. So I think that with Emdogain, definitely we have with hyaluronic acid. I always combine it with connective tissue. And that's why it is very difficult to say whether the effect is due to the connective tissue or due to the biologics. But thickening of the tissue, I don't know, but increase in the width of keratinized tissue is can be expected, but only around teeth, huh? Not around implants, because you need peroneal ligament for that.
Great. Friends, Shahram, off to dinner now for you. It was a great round. I think I learned a lot. You have a great scientific and clinical expertise, so much knowledge on one evening. Amazing. I think all of the participants, we were straight up over 400, up to 500. I think all of them were amazed by your presentations. I just conclude a little bit, and I think we see soft tissue increase of early vascularization of these materials, which will help us a lot. And I thank Shahram for not hyping one of these materials over the other. I think that's a great point. And not over exaggerating the effect of these materials. I mean, we're looking into small defects, but still, for me as a periodontist, I mean, the backbone is primary wound closure, and primary wound closure is depending on early vascularization. And I think definitely this is what we have learned today, that all of these agents will be capable of doing this. With this, I say hello again to Rome. I say hello to Frankfurt. I say hello to Bern. I hope there's no snow already in Rome and sun in Bern, but and rain in Frankfurt, I guess. Anyway, great friends. Thanks again to Regenerate. All the questions which have not been answered, the organizer will collect them and pick them up and bring them together, so all your questions will be answered. Hello into the world, and thanks, friends, for joining us and for doing that evening with us. Again, thanks, Andrea, Shahram, and Tony, and see you all soon. Ciao, ciao.
Thank you very much.
Bye.
Thank you, Tony. Thank you, Andrea. Thank you, Stefano. Bye-bye, everybody.
Arrivederci.
Bye, bye. Ciao, ciao. Cheers.